Hello, this is Mrs. Castillo again. We are going to start with part 2 of the neuro, and we will start with encephalitis, which is on page 959. It's a direct invasion of the CNS by a virus or post-infectious involvement of the CNS after a viral disease. Encephalitis can occur with certain childhood viral illnesses such as mumps, measles, varicella, which is chickenpox, rubella, which is German measles, or mononucleosis. A much more serious type of encephalitis is caused by herpes simplex virus, which is HSV. HSV rarely infects the brain, but when it does, it can be life-threatening. There is also West Nile virus, which first arrived in the United States from other parts of the world in the late 1990s and can cause encephalitis as well. Many people who are infected with the virus that can cause encephalitis have only mild symptoms. Symptoms in people who develop encephalitis may appear suddenly and include headache, fever, sensitivity to light, which is the photophobia, loss of appetite, stiff neck, and back. In more serious cases, there may be high fever, nausea, vomiting, confusion, double vision, personality changes, problems with hearing and speech, hallucinations, sleeplessness, clumsiness, muscle weakness, loss of sensation, irritability. In most cases, severe cases, there could be seizures or loss of consciousness may occur. A person who has any of these symptoms requires immediate medical attention. Now, if you look on page 954, box 28-5, you will see the clinical manifestations there. Our diagnostic tests that we use, of course, we'll look at the clinical findings. The patient may be ordered to have a CT MRI, EEG, a lumbar puncture, a brain biopsy if there is something there to biopsy, and antibody testing. Our patient goals will be to maintain airway throughout hospital stay. Patient will not sustain any injuries during hospital stay. Patient will demonstrate pain management by decreased heart rate, restlessness after medication administration. Nursing diagnosis is inability to sustain spontaneous ventilation, risk for injury, pain, of course. Treatment really depends on the etiology. Hydrocephalus is on page 967, and it is what we call an imbalance in the production and absorption of CSF in the ventricle system, and we're talking about brain. Results from either impaired absorption of CSF or obstruction to the flow of CSF within the ventricles. It can be congenital developmental defect or acquired. Now, if it's congenital, it accounts for most cases from birth to 2 years of age. Acquired is usually from lesions, infections, hemorrhagic, or pre-existing developmental defects. Production is an increased absorption causing accumulation of CSF within the system, and this can produce a passive dilation of the ventricles. If there is an obstruction or a blockage, it could be from a tumor, or there could be a communicating issue with the ventricles, inadequate drainage, perhaps. Clinical manifestations, the early sign is a rapid head growth, and they do head circumferences frequently on these patients. Bulging fontanelles, prominent scalp veins, irritability, lethargy, poor feeding, failure to thrive, translucent skin, increased tone, hyperreflexia, and declining LOC. Now, late stages would be a shrill, high-pitched cry, difficulty in swallowing or feeding, sunset eyes, vomiting, cardiopulmonary depression. In older children, they'll have an increased ICP. Now, diagnostically, I told you that they do head circumferences. Clinical manifestations can be an increased ICP on older children. They will do a CT or MRI, and they're looking for enlarged ventricles. You can find these clinical manifestations on page 968, 28-10. Now, therapeutic management, they can remove the obstruction if there is one. They can put a shunt placement, and there's different types of shunts that they can put in. Ventral gluteal ventricular peritoneal VP shunt, or ventricular arterial shunt. These are used in older children without heart disease. And then they can have an external shunt a lot of times, but of course, remember, with anything external, there is risk for infection. Please look on page 969 for post-op care with these patients. The number one complication with a shunt is infection, of course, and mechanical obstruction. Other complications could be subdural hematomas, peritonitis, because you are shunting the fluid into the peritoneum, abdominal abscesses, proliferation of abdominal organisms, fistulas, hernias, and ileuses. You need to be able to identify signs and symptoms of shunt infection, and those would be complaints of headache, change in LOC, low-grade fever, malaise, nausea, irritability, even after fever subsides. Treatment, antibiotics IV or intracannula, which is about 4 to 7 days. External ventricular drainage for persistent infection. Our outcomes. Well, our outcomes would be patient will remain free of infection while in hospital. Patient will assist with exercises indicated by physical therapy to improve muscle control by week 1. Parents will verbalize support systems available. Our nursing diagnosis will be risk for infection, impaired physical mobility, risk for caregiver role restraint. Spina bifida is found on page 1098. Spinal bifida is a part of the group of neural tubal defects in which the backbone and spinal canal do not close before birth. The embryonic structure that eventually develops into the brain and spinal cord is called the neural tube. In babies with spinal bifida, a portion of the neural tube fails to develop or close properly. This congenital disease results in spinal cord and backbone defects. Midline defects involving failure of the bony spine to close are called spinal bifida. It is the most common defect of the CNS. Often occurs with hydrocephalus and Chiari malformation. Now there's 2 types of spinal bifida. Spinal bifida occlusiva, which is it's not visibly external. You may see abnormal tuft of hair, a collection of fat, maybe a small dimple or birthmark, slight to pronounced skin discoloration. Now with spinal bifida cystica, it's a visual defect with external sac-like protrusion, and that's the one you see on the slide. There is no certain cause of spinal bifida, but rather it is a result from combination of genetic and environmental risk factors. Risk factors range from family history to improper peritoneal care, prenatal care. Race is a risk factor for whites and Hispanics to develop spinal bifida more commonly. Family history is a very important risk factor as it is seen to follow genetic lines. However, a great number of babies born with spinal bifida have no known family history of such conditions. Folate, vitamin B9 deficiency increases the risk for neural tube defects. Many foods are fortified with folic acid as well as prenatal vitamins. Women are encouraged to take folic acid during their childbearing ages. Diabetes and obesity are associated risk factors. Some evidence to cause spinal bifida are suggested increased body temperature in the early pregnancy, weeks of pregnancy, which would be if mom had a high fever or if she exposed herself to saunas and hot tubs during that early pregnancy. There are 2 types of spinal bifida cystica. There's the meningeal seal which is encases meninges and spinal fluid, there is no neural element and no neurological defect. There's also the myelomeningeocele, which contains the meninges, the spinal fluid, and nerves, and it does have a neurological defect of varying degrees. See this on page 1098. Now, we can do a prenatal detection of spinal bifida cystica, and usually you can see this with a maternal serum alpha-fetoprotein. You may see this on ultrasound. You may be able to detect it in an amniocentesis. Other clinical manifestations can be seen. Also, you can maybe see MRI, ultrasound, or CT. Remember, this is very important, the use of folic acid has reduced the incidence of spinal bifida in the United States. Clinical manifestations that you may see once baby is born is problems with physical movement, loss of sensation like heat and cold, loss of bowel and bladder control, twisted or abnormal legs and feet, and hydrocephalus or Chiari's malformation. Now, Chiari's malformation is a neurological condition in which an area at the back of the brain, known as the cerebral tonsils, is pushed down beyond the bottom of the skull into the spinal canal. As a result, the tonsils can physically block the circulation of the cerebral spinal fluid in the subarachnoid space surrounding the brain and spine, and may cause secondary intracranial hypertension and other serious problems. Now, there can be a prenatal surgery done, and that's done before 26 weeks gestation. Also, of course, there will be a postnatal surgery, and closure is usually done within the first 12 to 18 hours to prevent infection and trauma to the exposed tissue. A shunt can be placed for hydrocephalus, and we also remember that this is really important to prevent infection. With these kids or these babies, there will be a multidisciplinary treatment. So you will see a neurologist, a neurosurgeon, pediatrician, urologist, orthopedics, rehab, PT/OT, social service, and specialized nursing care. These patients and family need to be exposed to support groups. There are plenty of them out there. Our outcomes, of course, patient will experience minimized risk of CNS infection during hospital stay. Patient will not experience trauma to spinal lesions or a surgical site during hospital stay, and patient will not experience adverse effects of increased ICP during shift. Patient will experience minimal exposure to latex throughout the hospital stay, and this is getting actually much better. Now we have a lot of latex-free gloves and latex-free equipment. Nursing diagnosis would be risk for infection, risk for trauma, risk for injury. Management, of course, orthopedic, there'll be an evaluation. They'll evaluate the locomotion problems. They may use corrective devices, and they might even need a procedure to help with these locomotion problems. GU, they may have a neurogenic bladder dysfunction, urinary incontinence, and they may initiate regular emptying of the bladder with a clean intermittent catheterization. That you will have to show mom and dad how to do this, because the patient will more than likely go home with a catheter or being straight cathed every so often. Bowel, there are some degrees of continence can be achieved with diet modification, regular toileting, prevention of constipation, and avoid rectal temps. Latex allergies, of course, are at high risk because their repeated exposure to latex during surgery or numerous bladder catheterizations. Cerebral palsy can be found on page 1090. It's a permanent disorder of movement and posture attributed to non-progressive disturbances occurring in developing fetal or infant brain. There are some activity limitations with abnormal muscle tone and coordination. It often involves disturbances of sensation, perception, communication, cognition, and behavior. Etiology, clinical features, and courses vary. Now, CP as a part of the brain has not developed properly. This might be because of a variety of events occurring before, during, or after birth. Most people think of cerebral palsy as a condition caused by problems during labor and birth. The most common cause of cerebral palsy is something that damages the brain while the baby is growing in utero. These antenatal factors can be found in 80% of those affected and include genetic problems, malformation of the brain, and maternal infection like rubeola or toxoplasmosis. Better maternity care has meant fewer babies are born with cerebral palsy due to birth trauma, but this has been offset by the improved survival of premature and low birth weight babies, who may be up to 50 times more at risk for cerebral palsy. Clinical manifestations can be found on page 1092 in box 32-1. The symptoms of CP may take some months to become apparent and depend on the type. There may be abnormal tone like stiffness or floppiness of the limbs and odd postures. In spastic cerebral palsy, which is 70% of the cases, the limbs become stiff and may be drawn in. The athotoid cerebral palsy is about 10% of cases, and the child develops involuntary irregular writhing of movements. There may be a lack of coordination of the muscles of the mouth, causing feeding problems such as slow feeding, engaging, and vomiting. Delayed motor milestones such as crawling, walking, weakness or paralysis of the limbs, and abnormal gait and slowness in developing speech and social skills. Other common problems include difficulty with walking, writing, eating, talking, dressing, problems with balance and coordination, difficulty controlling and maintaining posture, visual difficulties, hearing problems. Some children have seizures, and some have learning disabilities. On page 1095, it talks about nursing assessment and risk identifications and early identifications. Careful assessment for infants at risk for first 2 years, which we want to identify signs of muscular dysfunction as early as possible. And see early signs and symptoms on page 1093, box 32-3. Now, multiple sclerosis is a chronic demyelization and inflammation and scarring of the brain and spinal cord, progressive degenerative disorders of the CNS. It affects young adults. The etiology is unknown. Some research suggests genetic factors or viral infection, autoimmune disorders, but there's no definitive test. One of the biggest issues is that it's unpredictability of the disease. One moment a patient can be doing well, and in the next everything can come undone. It is critical to have an understanding of the nature of MS and recognize that our goal is to be as preventive as possible. Onset insidious and it's gradual. It has vague symptoms over months and years. It's chronic, it's progressive deterioration with readmissions and exacerbations. Motor, sensory, and cerebral emotional problems, weakness or paralysis of limbs, trunk, or head, and spasticity of muscles. They can have numbness, tingling, blurred vision, vertigo, tendinitis, decreased hearing, and neuropathic pain. Bowel and bladder function is also affected. They could have constipation or spastic bladder. Multiple sclerosis means that a patient has more than one sclerosis. A sclerosis is a plaque or hardened tissue. People with multiple sclerosis have these plaques or lesions in the white matter of the brain or spinal cord. White matter contains the axons, which is the nerve endings, that connect neurons and allow them to communicate with each other. Specifically, MS means that there has been a breakdown of the myelin sheath, which is the protective layer surrounding the axons. This breakdown is known as demyelinization. When the myelin sheath thins and breaks down, the axon cannot function correctly, and electrical signals can't travel between the neurons. Although the myelin can rebuild itself, the rate of demyelinization caused by MS is too rapid for it to keep up. In some cases, the axon is cut completely. Initially, myelin sheaths of the neurons are attacked, but nerve fibers are not affected and nerve impulses still transmit, but slow down. Myelin can regenerate and symptoms disappear, resulting in remission. Disease progression disrupts the myelin totally, involving the axon, and forms hard scar tissue. Impulses are totally blocked, and permanent loss of function. There's no single multiple sclerosis patient that is the same, which makes individualized care plans critical, not only for their physical but also emotional well-being. So included would be PTOT, speech, pain management, an infusion center, gastroenterologist, general neurologist, and urology services. There are several drugs that are marketed for long-term treatment of the disease. Interferons. Interferons are proteins synthesized by the body that are involved in intracellular communication and play an important role in the immune system. Have an anti-inflammatory activity. These interferons used to stabilize or slow the progression of the disease. Immunoglobulins can be used. These are proteins found in blood as antibodies involved in immune reaction in the body. The effectiveness of immunoglobulin treatment is not yet established. Glutamine acetate is mostly used in patients with mild symptoms. Immunosuppressants, these are drugs that block immune responses. Now, when they do have acute exacerbations of this disease, they do treat them with anti-inflammatories. They are used mainly to treat acute exacerbations. Remember, though, with these drugs, they can increase the patient's glucose, blood glucose, and insulin may be needed to combat those high glucose levels. Diagnosis. Nursing diagnosis would be impaired physical mobility, self-care deficit, or risk for impaired skin integrity. I'm going to stop there, part 2, and we will start with glaucoma in part 3.